So I just am going to introduce Lisa. This is Lisa Bell, and Lisa has been practicing therapy for over 20 years, and she's worked in a variety of different types of settings. She started out in more of a neuro rehab type environment, and then has also worked in UCSF and Aspen and over at Kaiser. And so anyway, but our last probably 15 years have been in orthopedic rehab, but she kind of incorporates the neuro with the sports medicine, so it's a great combination. And she's also an amazing teacher, so we're really lucky to have her here. And so I'll let Lisa take it from here.
All right, thanks. Thank you. We're going to talk about how to keep your shoulder healthy. I think a big part of it is teaching you how to take care of your shoulder, because no matter what you do in therapy, if you're not taking care of it outside, then a lot of times you won't progress or you'll still have problems. And then also, hopefully you're not going to therapy the rest of your life, and eventually you're going to graduate, but it's something that takes some maintenance if it had some shoulder problems. So I'm going to go over some of the anatomy and start with the bony structures and point out the things that are kind of the most important. I have a small picture on your handout, and I wanted this picture because it includes the spine in the back, so we realize how important that is, and then the rib cage in the front. So most people think about the shoulder as the bones around here, and that includes this long bone. Your upper arm is the humerus. And what's important about that is the top or the head of the humerus. There are bumps, 2 little bumps in the front, and that's where the rotator cuff muscles attach in the front of it. And then there's a groove that the biceps tendon runs through. In the front, there's the clavicle or the collarbone. And then this joint here is called the acromioclavicular joint. The acromion comes off of what's known as the shoulder blade or the scapula. So the acromioclavicular joint is another spot which oftentimes people have problems with in terms of underneath that space. It's an area called the subacromial space. If you've been to the doctor and they look at the x-rays, what they're looking at is what's called that subacromial space. Because in that space between that acromion, which is the end of the shoulder blade, and the humerus, is where the rotator cuff tendons run through. And so a lot of times, even from an x-ray, they can tell if there's a massive tear of a rotator cuff, that humerus, the top of it will actually be pushed upward. And if the bursa, there's another structure there called the bursa, which cushions, if that's inflamed, then that can irritate that space. And then if you look here, you may not realize, but the shoulder blade, which is the end of the shoulder blade, is the socket part of the shoulder. So it's a ball and socket joint at the shoulder. The ball is the top of the humerus. The socket is the end of the shoulder blade. But the shoulder blade really is not attached to our skeleton at all, bony-wise. So the only place that your arm is attached to your skeleton is actually in the front, right here. The rest of it is attached through muscle support, and that's a crucial area, because the position of that shoulder blade is what we found to have some of the greatest effect on what's happening at the shoulder joint. So it's the base, that's the part of it there. Let's see, I'm going to go through here and go on to the muscles. So we're getting to the attachment. So how is that arm attached to the body? Well, any joint is attached to our body through ligaments. Ligaments connect bones to bones. So they're passive structures. They're not something that you consciously move, but they hold everything together. And in the front, you have ligaments that attach and connect that acromioclavicular joint. And then around the shoulder joint, there's a series of ligaments that connect, very strong ligaments in the front and the back, and they form into a thickening called the capsule. It's known as the capsule, and it's kind of like the shrink wrap around the shoulder. So those are the passive structures. And then the muscles that attach if we look here superficially, so on this side, these are the top muscles that attach from the shoulder blade to the spine. This is the upper trapezius, the middle trapezius, and the lower trapezius. And so those form the basis of what are called the scapular stabilizers. If you peel those away, underneath those are the rhomboids. There's a little muscle here called the serratus anterior. It's kind of right under. It goes from the bottom angle of that shoulder blade to our ribs. There's a muscle up here called the levator scapula. It goes from the top of the shoulder blade up here. So what you see is these all start and attach from the spine. And this is very important, as I'm going to point out later. Now we go to the front because everyone's asking, well, what about the rotator cuff? And that's what everybody wants to know about. So the rotator cuff muscle bellies rest on the shoulder blade. So here's the shoulder blade, and the muscles are actually starting from the shoulder blade. And I want you to think about, again, the shoulder blade is just kind of a floating bone. It's not attached bony-wise. And these muscles start from here. They're in the back. There are 4 rotator cuff muscles. The supraspinatus, which is above what's called the spine of the scapula, the infraspinatus, the teres minor, and then there's one more called the subscapularis. And that actually you can't see because it's on the inside of that shoulder blade, between the shoulder blade and the ribs, and that wraps around. So all those muscles wrap around. They start at the back, and then they wrap around the front, and then they attach to that humerus or the bones in the front here. So the muscle bellies are actually back here, but they're attached in the front. Now what I'm going to talk about is the purpose. A lot of people may think, oh, I'm tearing my rotator cuff when I reach my arm up, you know, and move it, and that's how I'm strengthening it. But what the rotator cuff muscles do, what we found is more than being a mover, a prime mover of the arm, is they actually stabilize the shoulder. So again, if we go back to remembering it's a ball and socket joint. And so a ball and socket joint has multiple planes of motion. It's multi-axial. That's why we can move our arm in many different ways. But because of that, it also is dependent on stability. And so if I'm moving my shoulder, so if I'm moving my arm upward, and this isn't moving on the right axis, and this part, this hand is going to represent that acromion, that piece that comes off of the shoulder blade. If this doesn't spin on the right axis, so I'm moving my arm up, then instead of it moving nice and smoothly, and these are the bumps where those muscles attach, instead it'll go like this, jam, jam, and then it starts to pinch on those rotator cuff tendons. This is a classic case of what's called impingement syndrome. And that's something that's used a lot. You'll hear a lot of people say, I have impingement, or the doctor says you have impingement. And true impingement comes from if you reach in certain motions and go, ow, and it pinches, ow. And it's typically overhead motions or sometimes out to the side. But you can also have, and you may get that pinching because of that lack of motion and that ride in the humerus. You may also get that from the shape of your bone. So the acromion that comes off of the shoulder blade, when they look at the x-ray, they classify it as type 1, 2, or sometimes 3, I think, but typically they're going to look at 1 and 2. And what that means is, does that acromion rest like this, or does it tip downward? And if it tips downward, then that takes up space. Okay, so that takes up space for those tendons running. The other thing that takes up space is just if you do a lot with your shoulder and then you get inflammation. So you're out working in the yard and you're chopping and pruning things, and then this gets inflamed at the tendon attachments or the bursa. So remember that cushioning sac in there? When that gets inflamed, then it really hurts. So that takes up space in that subacromial space, and then you go to move and it hurts even more. When things are really inflamed, then it will often hurt even when your arm's down. So if you're just impinging, it will only hurt if you're moving in certain positions. When you start to get a bursitis or tendinitis, then it hurts even when your arm's down at your side, and it really becomes painful. So some people start to have problems because the capsule or those ligaments around the shoulder start to shorten up. And so this can happen from a number of different reasons. But here's one of the easiest ways for it to happen. So we're going to talk about posture. It all starts with good posture. And whenever I talk to my patients about posture, they'll say, well, my mother used to say that to me. And so remember how I talked about those muscles attaching to the spine, and it's part of the spine? So the most common postural dysfunction that people end up with is the classic forward head, and then the shoulders round forward. So if my head goes forward, then those muscles that attach from the shoulder blade to the neck and the spine get wound up, and then certain muscles, like this one here called the levator scapula, instead of letting that shoulder blade rest, if you look at it here on a nice plane, the top of the shoulder blade's like a triangle, and the top is kind of a cross, and this one is pretty far up and down, and then there's an angle here. If the muscles change position, then that shoulder blade, if this is tight, then that may pull this part of the shoulder blade up, then this part of the shoulder blade goes this way. So that triangle is tipping this way. Can you picture that? So then that space there, that's another thing that takes up that space. If that triangle then tips downward, then that bone, that acromion, instead of it resting here, it's now resting here. So you've taken up that space. So that forward head posture changes the angle of the scapula or the shoulder blade. And then you can get what's called an overstretch weakness. So the muscles, yeah, do you want to scoot over?
Now I don't have to
That's
look
good
at the
because it's
bowl.
full, I know.
I'm going like this around the bowl. I don't, wait a minute.
So the muscles that attach from the shoulder blade to the rib cage, if I start to get in this kind of posture, they stretch out like a sweater that's stretched out and won't go back. And muscles operate on what's called a length-tension relationship. They've got to be at just the right length to create the right amount of force. If they're overstretched, then they can't work well. By the same token, if they're too tight and they're too short because they move like this, then they can't gather. So they've got to be at the right tension and length. And so typically that forward head posture starts to change the length-tension relationship of all those muscles crossing from the shoulder blade to the neck. Then, if you can imagine if that shoulder blade is tipped downward, and then the shoulder blade's not stable on the rib cage, is what we call it. And so if I'm trying to then take and use the rotator cuff muscles that are attached to the shoulder blade, I'm trying to use them to hold that ball in the socket and to seat it correctly, they can't work because I use the analogy of, imagine if you're on a raft and someone's trying to get on and you're trying to pull them on. If you're standing on a raft that's moving, you might just get pulled off with them, right? It's on an unstable surface. But if that raft was anchored, then you could help them on. So if that shoulder blade or that scapula isn't anchored well and it's unstable and it's not moving the right way, then the rotator cuff muscles can't work the right way to stabilize that humeral head. And then you get this jamming and pinching and you get this tugging. If that shoulder blade, if the humeral head, I should say, starts to shift forward, which is the next thing that happens, it kind of drops forward, then the biceps that are in the front, it pushes on the biceps tendon that attaches in the front. It starts to pinch some things in the front and tug some things in the back. And then you start to get pain from multiple different structures. And so it kind of keeps going there. When you get pain, pain also changes the way your muscles work. So what we examine when you come in for therapy, a lot of times the first thing will be I'll look at someone, instead of looking at you from the front, I'm going to look at you from behind. First I'm going to look at where does your shoulder blade rest when you're just standing there. And a lot of people, they're downward tipped or forward. And then when you move your arm, what happens? So when I move my arm, the humerus moves, but the shoulder blade should move. So the shoulder blade should actually go up with it, like that. And it moves on a 2-to-1 ratio. So for every 2 degrees of movement at this is called the glenohumeral joint, or the shoulder, there should be 1 degree of movement at the shoulder blade. A lot of times it's more about the timing of it. So when someone reaches up, I'll see that shoulder blade poke out, the inside angle poke out. We call that winging. And it might wing on the inside, it might wing underneath, it might wing on the top. And basically it's a sloppy shoulder. And that's what we call scapular dyskinesis. so the scapula is not moving well. And this is something that they've started to look at a lot more in terms of what controls the movement of the arms. And looking at the scapular dyskinesis, they've identified that as a major problem in one of the most common groups of people that have shoulder problems, baseball players, especially pitchers. And so you end up having a lot of fatigue of certain muscles that attach, and then the scapula gets sloppy and doesn't move well. And then in baseball players, say a pitcher, what happens is they start to lose velocity, they start to lose accuracy, so they can't move the arm well. And by the same token, that can happen with all of us. You start to have trouble actually, doing any work around your house and using your arms, and might get fatigued and tired and sore. And so those muscles aren't working well. So we start with retraining that scapula, or the shoulder blade. And then the cuff muscles need to be trained to stabilize the shoulder. And it's more about a sensation of getting them to seat the ball in the socket, rather than kind of lifting 100 pounds, that kind of thing. So that's one of the primary goals that I have when I work with somebody is, first of all, we started with correcting the posture, and then we're going to start with changing the shoulder blade movement, and then we're going to get out here and change what happens at the shoulder joint itself. So a lot of people come in and we won't even start here. The first day it's just postural muscles and changing that position, because our habits of movement are what get us in trouble. So I've seen a lot of people where they have a habit of the head moves with the arm, like this kind of thing, or they have a habit of hunching. So this can happen when you have weakness and when you have pain. Instead of that shoulder blade moving upward, it just goes straight up. Instead of it rotating, it hunches. And so people start to reach out like that. And that starts to shift and jam that humeral head up. So it's changing those habits of movement that's important to start out with. And then if you have symptoms, it's addressing those symptoms. Okay? So before I go into symptoms or treatment, any questions on what I've gone over? Yes?
What exactly is the labrum, and how does that work into the anatomy of the...
Yeah. So the labrum is the gasket. So the humerus, or the glenoid fossa, which is the end of the shoulder blade, is actually pretty shallow. Can't really see it that well here, but it's actually pretty shallow. And the labrum deepens it. So the glenoid fossa is actually maybe like this, but the labrum sits there, and so this is a piece of connective cartilage that sits there and deepens it and makes it more of a socket. So the labrum is something that can get injured when, with wear and tear around the shoulder. Again, if that humeral head is not moving correctly, then it starts to pull on the attachments. Typically, one of the things that pulls it off the most is the biceps actually attaches into the labrum. And so a lot of people end up, if you are doing a lot of work and the biceps is taking over, it can pull on that labrum. So you can have labral tears. You also get labral tears when you have instability or dislocations. So some people dislocate, and you might get dislocations from a trauma if you fall. Some people are chronic dislocators because they have ligament dyslaxity. So I don't know, can anybody do this kind of thing where they push their thumb down to their forearm? If you can push it all the way down, then you've got some ligament dyslaxity. And some people that have ligament dyslaxity will come in, and I've heard histories where their shoulder will pop out, maybe starting when they're in high school, and then it wants to repeatedly pop out. But even if your shoulder pops out once, then typically the labrum can be injured because it basically peels off of the glenoid fossa.
Do they have a tendency to be fully self-repairable if they do have an injury? I'm speaking of the labrum.
The labrum, you mean?
The labrum, yes.
The labrum. So it depends on how much is torn. to evaluate the labrum, they have to do an MRI. And 2 classic labral injuries are something called a SLAP, which is superior labrum anterior posterior, and that's where it's torn at the top. And then Bankart, which is, that's actually, a Bankart is the ligaments. Those are usually coming along when people dislocate. But over time, we all have some wear and tear of the shoulder. So here's the other thing, is that if you took, even if we took a group of people that are asymptomatic, that are not having any shoulder problems, after the age of 60, probably 10% are going to show some rotator cuff tear and rotator cuff injury. So our bodies don't last forever. They do wear out. So here's the question is, if you have shoulder pain and then you do an MRI and it shows all these things wrong with it, does that mean that these things need to be repaired or not? And that's something else that's being kind of looked at more these days in terms of what are we really doing when we go in and repair it? Because unfortunately, there is a good number of rotator cuff repairs that actually fail. So they actually, if they went back in, if someone comes, and usually they're not going to redo an MRI after a surgery unless someone's having problems. So maybe someone comes back in and they've fallen or it starts to hurt. But some of those people can go on to full recovery. By the same token, I have seen patients come in by MRI documented full rotator cuff tear. So that means all 4 tendons. And that usually doesn't happen until much later. So you might have partial tears. But completely gone, yet they can move their arm all the way up and around. Yeah, complete tear. And we have deltoids that can substitute. So there is a protocol that I use for people that have full rotator cuff tears where you retrain the deltoid, and it's amazing. It's like magic. It's not fun. It hurts a lot while you're going through it, but as you're recovering from any type of shoulder problem, the first thing is starting to modify what you're doing. So avoiding aggravating activities, and this is universal for any kind of injury. Because I always use the analogy that if I punched you once, it might hurt for a little bit, but then it doesn't hurt again. But if I kept punching you in the same area, soon when I stop punching you, it would hurt. And that's because you have a bruise and you have tissue damage, right? So if you go and do something and you go, oh, that hurts, and you stop. But if you keep going back and doing it again and again, after a certain point, you're going to damage the tissue. If you just do it once or you do it a few times and go, okay, I'm not going to, I'm going to avoid that right now, then maybe it can heal up. But the more tissue damage you incur, then the harder it gets. So now we're going to talk about how to be good to your shoulder. And so if you do have symptoms, what you want to do is try to minimize lifting with a straight arm. It's just the physics of it. If your arm is straight, it's a longer lever arm. If your arm is bent, then you have a better advantage to use the muscles around your shoulder. So rather than lifting into that shopping cart straight up, I might go around it, slide something towards me, and lift from here. Okay. Another thing is minimizing repetitive activity. So instead of going out and pruning, bless you, pruning for hours on end, if my shoulder has been giving me problems, I might go out and do it for about 10 or 15 minutes and give it a break. It's going to take longer, but again, that repetitive motion is something that starts to cause fatigue of the scapular stabilizers and fatigue of your shoulder. As soon as muscles fatigue, then the movement gets sloppier, and then you're more likely to cause injury.
But you do, in terms of repetitive exercise, in an intelligent way,
right?
Which
exactly.
not like just picking up 500 pounds. I mean, but what I'm saying is, you can train the muscles to get. A muscle will respond.
Yes.
And can get stronger.
It can get stronger.
So if for instance you go and you wash your car,
right?
And
right.
that's it. Let's say that's 20 minutes of, like.
Right.
This circular motion, and at the end of that, you say, "Oh, this is abnormal in terms of feeling."
Right.
You can tell that the shoulder is not happy with that.
Right.
But yet, if you engage in a concerted program of physical fitness,
yes,
you can, and you make the muscles which support that action stronger, you would think that you wouldn't get that result from, once again, from doing that motion.
Right,
Or
so
is
you
that
would
not-
think that you would build up the endurance, is that what you're saying?
Correct, right,
Yes.
yeah.
Yes,
That's not the
yeah,
way.
exactly. If you are strengthening the right muscles. So I put it in terms of washing the car or anything you do throughout the day is function. And I always say that's kind of like, that's your game. When I'm washing the car, when I'm doing this motion, I'm using a whole bunch of different muscles and I'm doing a lot of different movements. But the exercises, what I'm talking about is trying to isolate for you. Compared to you, you might have weakness in one area, you might have weakness in another. You might be tight in one area, you might be tight in another. And so for each person, they might have individual areas that they need to work on. And so when this whole movement, it may be that you're getting in trouble because of one particular area. So part of it is kind of finding out where your deficits are and addressing that. But it's also about using the right body mechanics with the movement. So if I'm doing it, I'm punching, or I'm like this, it's not good. And it's about listening to your body. So if you do that for that 20 minutes and you start to realize, well, I'm not feeling good, you might say, I'm going to lay off for now and then let me see how I feel later. And then the next time you do it, you say, well, maybe I'll just do it 15 minutes at a time while my shoulder's still bothering me. If you go and you work on your shoulder and you build strength and you notice the next time you go to wash the car, you can do those 20 minutes and suddenly it feels different. It doesn't seem like it hurts as much. I think that's where you can tell that you've built up some of your functional strength. So I always say that, everyone says, I do a lot of exercise. I go out and wash my car, or I climb stairs. But that's function. And so when you're doing these exercises separately, it's just like no professional athlete would go into a game without being prepared. Unfortunately, as things change and if we get injured, you may not be able to do that functional exercise or that function that you want to wash the car or play tennis without doing some exercises first to prepare your body for it. Does that make sense?
So like going to yoga or to do supplemental exercise.
Yes, exactly. Yeah. So yoga, Pilates,
Or weightlifting.
weightlifting, there's different ways. So what I'm going to give you today is some basic exercises. By no means are they going to cover everybody because I don't know everybody's individual issues, but there's some basic ones, they won't harm anybody. And I gave everybody some things that really be minimal to no equipment. But definitely if you have access to a gym and a Pilates studio, yoga, those are, I advocate all those types of exercises. As far as the posture, I'm going to go ahead and demonstrate something right here. Everybody go ahead and kind of slump down there. Okay. And now raise one or both arms up. Raise your arm up there. Oh, and then come back down. And now everybody sit nice and tall. Imagine you've got a string to the top of your head. And it's the back of the head, so it's not the front. Your nose should be up. It's the top and back. And now raise that arm up. Oh, did everybody raise their arm higher?
Yes.
Yeah, immediately. You're healed. And then if I check how important posture is. So, 2 postural exercises that are on here, well actually 3, are first imagining that strength to the top of your head. And this is an exercise. You actually have to train yourself to keep good posture. And a great way to do that, because oftentimes too, we end up with poor posture and head goes forward. We don't even realize it's happening. And I'll say, stand up straight, and I'll go, I'm straight, here I am. You can check yourself by going to a wall. Put your hips against the wall. Put your shoulder blades against the wall. And if my head's still forward, you've got to bring it back to the wall. And you want to bring it back by tucking the chin and sliding the head back. Rather than, if you have to bring your head back to the wall and then your chin tilts up, it means that you're missing some motion at your neck. So you might be stiff at your neck or you might have tightness. And so I don't want you to force the head back and have the chin poke up, but I'd rather have you keep your eyes level and come back as far as you can, but work back to getting that head back. So we're looking at, if we look from the side, the ear in line with the shoulder in line with the hips. And then you're going to walk away And you have great posture for about 30 seconds. You start to do this there. And then we sit, and in sitting, it's always more difficult to have good posture because our hips are flexed. It tends to flatten our lumbar spine, and then oftentimes we're sitting driving or using a computer, so then we start to do this and poke the head. So this is why I also recommend the 20-20-20 rule for sitting and using a computer every 20 minutes. You should get up for 20 seconds and walk 20 feet away. And I actually kind of took that from a protocol that was used to reduce eye strain. They tell you to look 20 feet away. I tell people to walk 20 feet away. You're going to reduce your eye strain because you're looking away from the computer, but also as soon as you stand and your hips extend, automatically most every one of you is going to have better posture. So actually, let's everybody stand here because you've been sitting for about 20 minutes. Have everybody stand up. There you go. And now try that strength to the top of the head again. It should feel easier, right, when you're standing. Hips straight, and tuck that chin a little and slide that head back. There you go. And everyone says, then I have a double chin. It's not so far back that you're forcing it, but I want you to feel like the back of your neck is getting longer. The muscle that you should be using at your neck is deep inside your throat, behind your throat here. And it's one that makes you longer and taller. Now the shoulders, let's try, lift them up a little bit and lift them back and then down. And this is resetting the shoulders. So when we sit, there's that tendency to roll the shoulders forward, and then our pectoralis muscle tightens and shortens, and that rolls the shoulder forward even more. It pulls that humeral head forward. It also takes your shoulder blade and tilts it. So when you do this, you come up, back, and down. It should feel like that shoulder blade flattens on your rib cage. This is called setting your shoulder blade. So you're setting that raft and getting ready, and then when you reach and move, it should feel like it's more stable. And I want you to practice reaching and moving without poking the head, without hunching up, but feel like it's moving from the shoulder blade. So 2 postural exercises. You can do the first 2 postural exercises every time you're in the car driving at a stoplight or stop sign. Tuck the chin, set the shoulder blades. Tuck the chin, set the shoulder blades. Okay? So that's the start of it. You can have a seat if you'd like. So I did write in here, tuck them in your back pockets, lift and flatten them on your ribs. And the tucking in the back pockets just refers to sort of setting them down, and that uses a muscle called the lower trapezius, which oftentimes is very weak. But I also want you to think about flattening on the ribs, because some people actually are too far down. So I don't want people that's shoulders slope downward to necessarily push them downward, but I want you to feel like your shoulder blades are set against your ribs. And it's a little tricky, because a lot of times if you've had problems with that, it's hard to tell where it is, okay? But when you stand against the wall, you'll feel if that shoulder blade is kind of poking out, and you can flatten it in there. So now we're going to get to some stretches. So I just came up with 3 stretches. They're ones that I think anybody can do. The thoracic spine, the first stretch called the prayer stretch, and this shows this person on the ground, but you can do this from a chair, sitting in, let's see here, this is sideways, I should have it the other way. If this were in front of me, I could just sit at the dining room table, put my elbows like this, and then slide back here. This is going to stretch underneath here. So a common area that gets tight or restricted around the shoulder is what's called the inferior capsule. And so this really stretches through that inferior capsule. The next one here is an unusual one. It's called the sleeper stretch. And this one is to stretch another area that gets very tight called the posterior capsule. This is a really a problem area for a lot of people. The posterior capsule that attaches kind of back and underneath, when that gets tight, it pushes that shoulder forward. And remember, we want that shoulder, if you look at it from the side, we want this back and in line with my ear and in line with my hip. And so when this gets tight, that pushes that forward and puts it in a bad position. The sleeper stretch, what's this showing is lying down, but I can show you in standing also. If we stand, and I put my arm, if I'm lying down and I'm stretching my right shoulder, I want to bring the upper arm 90 degrees away from my body, the elbows bent. I take the other arm and press the forearm this way. And so what I'm doing is I'm on my right side just enough to be on my shoulder blade. I don't want to be on the shoulder like this, but just on the shoulder blade. The arm is out, and I press in and hold. And most people can tolerate this. So this is a variation of some people. You'll see swimmers that stretch this way, and that also stretches the posterior capsule. But if you've had some problems with the shoulder, sometimes this really pinches and it hurts. And so the sleeper stretch, you can do it standing like this, but it's really effective when you're lying down and you're lying on your shoulder blade.
So is he rolled a little bit backwards?
He's rolled.
I mean, is that what
Well,
you,
he
in order to
started
get on
out
the
backwards
blade?
and then he rolled a little bit forwards. Is
Okay,
what this
so
picture shows there.
So is your blade isn't flat on the,
It's just secured so it's not
Secure.
moving.
Oh, okay.
Yes, exactly. Because a lot of times, again, with this kind of stretch, what may
It's
happen is
moving.
if I do that and my whole shoulder blade comes forward, now I'm actually stretching back here. Remember, I don't want to stretch it back here necessarily, but I want to isolate it here. It's really hard to isolate just that spot there. So the sleeper stretch, I find, is one of the best stretches to isolate that posterior capsule. It's usually tolerated by most people, and is one that not a lot of people do or have heard of. And then the last area to stretch is through the front, one arm pec stretch. And so this is the chest. So the pectoralis and the pec major runs across through the front, and that pulls the humerus forward, or that ball forward in the socket. And then there's a little, the pec minor underneath attaches actually to a little piece of your shoulder blade that pokes through, a little bone that pokes through. So when that's tight, that tips that shoulder forward. So you get this. So these tight areas are pulling you forward. So the doorway stretch for this is one arm. I can actually kind of show you from here. If your arm's up, and then you step through the doorway. And I like you to step through with the same side, and your arm is up in, I call this like a half goalpost. It's like, this is a goalpost position, this is a half. Make sure you step through and keep your head in line with your body.
So you
so
kind
that
of
you're
lunge when you step through.
Yes, and you're stepping through, so that you're not doing this, poking the head through, but you're leading with your chest, and also that you're going straight ahead and not just turning this way or this way. So straight forward, and where you should feel it stretches through the front and the chest. Okay? So those are three. When you're doing these static stretches, I recommend you hold for 30 seconds. And you can do it a couple times twice a day. The important thing with stretches like this are not necessarily, you don't have to do 10 of them, but actually to do them daily. So you could do 1 minute of your day, each of them, okay? The next series I'm going to go through is for those scapular stabilizers. So scapular stabilization and shoulder blade strength. First one is called the push-up plus progression. Then there's floor or chair dips, and then the prone scapular series. So the push-up plus, if you look up here, is traditionally I'll start on the wall. And if somebody's got their hands on the wall, what I'm looking for is this, it's this little muscle here called the serratus anterior, which goes from the ribs to the shoulder blade. It lets me push myself away from the wall. So I'm pushing my chest away from the wall, and I'm taking this part of my shoulder blade, and it's coming forward. So if I'm at the wall, come over here again, and I might start, and a lot of people whose shoulder blades wing will see them kind of sticking out when they're here, and I'm going to ask you to push away. And there's my shoulder blade kind of flattening against my rib cage. Now it's not this, and it's not this, but it's this. So we call it the plus part because it's kind of the end of a push-up. So if you've done a push-up and you're here, that extra plus part is the shoulder blade movement. And that's a key part of doing a correct push-up anyway. So a lot of people might get hurt. I see people, if you're doing a push-up and you're sunk in here and I'm doing that, the whole time I'm doing that, my shoulder's jammed forward and up. Ow, that's going to hurt. So So if I can maintain this plus position as I do a push-up, then I'm going to be in a lower. The lower you go and you start to do the same plus from a table or from a chair, you can end up doing it straight from the floor. And then a great thing I like to do is have people do it over an exercise ball. So if you're over an exercise ball and actually just walking out over that ball, keeping your head and chest lifted, works that same muscle. But I would start
You
with
mean
an
your
easier
feet on the
version.
ball?
Yes,
Okay.
yes. So you're on your belly, and then you walk out over the
Oh, I
ball,
see.
and then you end up kind of in a push-up position with your feet over the ball. The further out you go, the harder it gets. I would start with the basics. So the floor or chair dips, and this gentleman's doing it kind of with the legs straight out. That's actually a really difficult position. Everybody here in your chairs, you can do the same thing. This is working the lower trapezius and the scapular muscles that bring the shoulder blade down. So in the chair, you can go through and hold here, and it's just a small bit of motion like this. So all I'm doing is lifting from my hips slightly. If you've got armrests on the chair, you can put your arms on the chair and kind of come up a little bit with the armrests. So go ahead and lift up, yeah, and then do an extra push. Plus. There you go. And then come down a little, and then up. There you go. That's it. Does that hurt? Okay. So if you're doing it from a chair, it's really just pressing down enough that the shoulder blades, the shoulder girdle depresses downward, and that's it. It's not a big motion. Yeah. If you go ahead and do it from an armrest, you sort of come up to almost a straight elbow position and then press. That's it. Yeah. And that's it. There you go. I used to have spinal cord injury patients do this with their legs up so that they're really dipping low, and that's when you're really using those muscles. And you can definitely progress it by getting your legs out in front of you and then using less and less support. And there's the machines at the gym also too. So that's a good exercise for your scapular stabilizers. And then we go to the prone series. And on this handout, it shows kind of 6 different positions. I'm just going to point out the top 2 and the bottom 2. So in the top, the A position is face down and the arms are palms down. And really what you're doing is going from arms down to just in line with your body. Make sure that if you're bent over, and I can do this also in what's called a bent over position. If I'm like this, and I bring my arm straight out to here. And so what I'm doing is coming from here, squeezing my shoulder blade in towards my spine to come out, and then down. So it's not this, where I'm only moving here, and what you see is this starts to poke forward. It's the whole shoulder girdle. So what you see is my shoulder blade coming towards the spine. The arm is actually just the weight. Okay.
So sorry, I don't quite understand. So your head is on a cushion. So you're trying to keep your chest off the ground.
No, that's just so you have breathing space.
Okay.
And also
Yeah,
head and
because
line.
yes, I'd like you to do it. Don't do it with the head turned to the side. I'd like you to do it with the head facing down. So that's just, you can roll up a towel and put it here, just so you have breathing space.
So you're raising your arms. It's not very.
No, I'm going to say he's doing it
See any
with both
movement.
sides. Yeah, exactly.
You know? I
You
don't know
might-
what the movement is here.
Yeah, I know. It's hard to go from a static picture. So he's doing it from both sides, and which is hard to do on a bed because I don't necessarily want you to just lift way up past your body.
Right.
But if you just did it from one side, kind of off the edge of a bed, so if I were on here and I had a towel roll and I was lying this way, my arm ends up hanging down and I come out.
Oh, okay.
And then the second position there, the B position, the difference is now his palm is forward
Mm-hmm.
and we're coming out. And that changes what muscle you're using. Because there's 2 different muscles that do a similar motion back here. One's the mid-trapezius, one is the rhomboids. So this biases the mid-trapezius, this biases the rhomboids.
Oh, okay.
For a lot of people, they find this more difficult.
Because
The
it's a
mid-trapezius
different
is
muscle.
usually,
So,
right,
yeah, rhomboids
weaker.
are usually more active than the
Yes.
low traps.
Yeah. And then on the bottom, I'm going to point out that E position where he's going like this. I wouldn't come up that high, but if I'm bent over, I would start here and just turn. And this is like I'm coming up to that goalpost position. So what we're doing is, in the goalpost, you're stretching what's tight here that's pulling the arm down and letting you come back. And then here, you're strengthening the muscles that externally rotate the shoulder and also the shoulder blade. So he's doing this kind of motion. I know it's hard to see. And then the F position, that last one, is down here. If I were doing it bent over, it'd look like this. And then I'm going to come up by my side. And again, I don't want to come way up here because that actually drives this forward. But all I have to do is come from here to here.
Are you, in that last one, it looks like his palms are facing down at the end?
Yeah, and the prone extension one?
Yeah.
I usually like to just have the palm
Neutral.
facing inward.
Neutral.
Yeah, exactly. Not necessarily an internal.
Yeah.
Right.
In C and D, are the differences there just that he's elevated his arms?
I
and
think that's
using low
supposed
traps
to be,
more?
right, exactly.
Yeah, it's for low
exactly.
traps, right?
That the arm is further
Yeah.
up, kind of more in a Y position.
Yeah, okay.
Right. And there are a whole bunch of different positions you can use. Another great place to do these exercises is over the exercise ball. Again, I like, actually, can I borrow that? And this way you can work both sides. So if you're over the exercise ball, and this is, I'll go backwards, this is extension. This is that external rotation. And then the top two mid-traps and round blades. And so this, I like the ball because you're also working your core to stabilize on it. And remember that head position though. So I do want to be in line here and not down like this, but I've got to be here. So, but it's also challenging for the neck. So if I'm someone who gets tired at my neck, I might have to take a little bit of break. But at the same time, you're strengthening those neck muscles too. Okay.
Yeah.
So, but it is more challenging. I'm a therapist. I could show you 1,000 million exercises to do and 1,000 different ways to do it. But these are some basic ones here. And we get down to the last group, and this is where we're targeting the rotator cuff. So we finally get to the rotator cuff. So they're known as the rotator because they rotate the humerus. So it's this axis that goes up and down, and the humerus is this bone. It rotates. This is external rotation, which typically the supraspinatus, infraspinatus, and teres minor produce external rotation. And then internal rotation is produced by the subscapularis. But when you're doing these, what I want you to focus on is stabilizing at the shoulder. So let me grab an exercise band over here. So these are the classic ones that a lot of people know. Liz, can you come up and be my anchor? You're going to have her be my anchor. So say I've tied this to something over here. If I'm going to do the first one that's called external rotation on my right shoulder, let me come over this way a little bit there.
Thank you.
Yeah, there we go. What I might try to do, this reminds you or tells you to use a towel in your armpit. And that's another key difference between a lot of what we're doing these days and the old ways of doing external rotation. We used to have you hold it in here. But we found if the arm is about 20 degrees away from the body, it puts the tendons in a better position for the blood supply. The other reason is when that towel is here, typically that will keep you from doing the wrong motion. So a lot of people might start to do this or this, and then I'm just extending the elbow or I'm lifting the arm. If I have the towel roll here, then I'm going to do this, which is external rotation. It's the hand away from the belly. Now if I'm strong enough and I can keep my arm in the right position, then I can just hold it here and rotate. So you see how my elbow's not coming in, but that requires muscle strength just to hold it here. And when I'm doing this, if you look at from the side, what I want to see is that shoulder doesn't shift forward or backward, but it moves on a vertical axis. So it's just rotating. Before I do that, I'm going to do what? String to the top of the head, set my shoulder blade, and then move. If I don't, if I'm here and I'm here, ow. A lot of times this will go forward. So this is a very common exercise. A lot of patients I've had come in and say, I was doing those shoulder exercises and they started hurting, but I kept doing them. And then they cause all this inflammation because they've done it in a poor posture, or they're doing this and the shoulder's poking forward. They're not setting it in the right place. This should not be painful. So these exercises are not the no pain, no gain type of exercises. These should not hurt. If it does hurt, then immediately if you set and change your position, you should find, oh, that feels better. You should be able to put it in the right place. Otherwise, you might need a lighter band, or you change the range of motion. Internal rotation, I'll go from the left side, is the exact opposite. So it's coming hand in towards the belly and then
Do you still want the same degree, the 20 degrees?
Mm-hmm. Yes, exactly. And then the last one, the disco diagonal, I'm sorry, but this picture shows this person lying down just because that's the only picture I had here of that. But I have people do this in standing. You basically hold one end at your hip and then the other out here, and you're coming up and out. So this is kind of one of the last ones. This would be one that, as long as you have good scapular stabilization, you're not having symptoms, then you can start to reach up and out. And it's a combined motion, so you start with the palm or the thumb facing downward, and as your arm comes up, the thumb is facing towards the ceiling. So you're rotating. You're actually rotating the arm, abducting the arm. And it's a diagonal pattern, which is how we move. In life, we don't just move like this or this, but we move in diagonals. And so it combines all those individual muscles that you just worked on to start to build some strength in a diagonal pattern to be able to do things like reach to a cabinet or to prune or grab things. And you can do it in the opposite way and have it secured up somewhere here, and also do a diagonal where you pull down and back. But most people are very weak kind of going this way. You can also do it without the band completely and just do that. And a lot of times that's enough if your shoulder has been feeling really weak or really sore, just doing it with the weight of your arm actively and building up your strength and endurance mostly. So you want these muscles to be able to last. And so I'd rather have you do lower resistance and higher repetitions to build endurance than go out and try to use a really strong band to do it. Okay?
I can do testimony on that.
Uh-huh.
I have